A one-eyed person had advanced glaucoma due to combined mechanism. AC was extremely shallow. He was on 3 anti-glaucoma eye drops with poorly controlled intraocular pressure, very advanced glaucoma changes in the visual fields. He had few attacks of angle closure. PI was done at 2 areas. There were posterior synechiae in the upper nasal quadrant. Anterior capsule was stained with trypan blue. The posterior synechiae was released. The pupil is rigid. Intracameral 1% lignocaine is infused. Stretch pupilloplasty is done in an attempt to enlarge the pupil to some extent, but it had no effect on the rigid pupil. Visco was injected into the anterior chamber, deepening it to some extent. Tunnel floor entry technique with cystotome maintains the anterior chamber adequately without the loss of anterior chamber due to seepage of HPMC in an open tunnel. The tunnel remains sealed. The entry into the eye is through the tunnel floor with the cystotome perforation. An adequate sized rhexis is done under the iris. The internal lip of the tunnel is now enlarged minimally so that you have a trapezoidal tunnel. Hydrodissection is performed very carefully, ensuring that the fluid does not seep through the zonules. The tip of the modified cannula is ensured to be kept inside the capsular bag. Nucleus is bimanually rotated using a 25 gauge cannula and a hook, Sinski hook. The nucleus is rotated into the anterior chamber bimanually. The visco is continuously being injected in front of the nucleus so that it is kept separated from the endothelium. Nucleus is hard, so it's bisected with the cystotome with a support behind with mini vectis. The cystotome is continuously injecting visco throughout this procedure. The heminucleus are comfortably extracted from the eye without putting a stretch on the tunnel. It's visco expression. Visco is being injected continuously to minimize damage to the endothelium, which could happen when an object is moving inside the anterior chamber. Meticulous control of intraocular pressure is possible with the Simcoe infusion aspiration cannula. The infusion is also not continuous. It's controlled by the fingertips of the surgeon using the silicon bulb. So meticulous control of intraocular pressure is possible as both infusion and aspiration are under the direct control of surgeons, guided by the microscopic view of the status of anterior chamber during surgery. As there is no side port, the subincisional cortex is aspirated using reverse Simcoe cannulas. The IOL is injected into the capsular bag, ensuring that the haptics go in the capsular bag. Complete cortical aspiration minimizes postoperative inflammation, and the IOL is now rotated into the capsular bag. The zonules are weak in this patient because of long-standing glaucoma as well as the medications that the patient has been using for a long time. Visco is aspirated completely from the capsular bag and from the angle region, and chamber depth is restored to normal intraocular pressure. The eye was not bandaged and was appreciated by the one-eyed patient. Thank you.